In this video, we will briefly describe the diagnostic criteria for somatic symptom disorders. These are diagnoses of exclusion that are characterized by symptoms or worry about symptoms that are unexplained or not fully explained by an underlying medical process. The diagnoses include somatic symptom disorder, functional neurological disorder, formerly called conversion disorder, illness anxiety disorder, previously known as hypochondriasis, factitious disorder, and malingering. Like other psychiatric disorders, in order to diagnose a somatic symptom disorder, you must first be confident that the symptoms are not due to normal or culturally accepted beliefs or behaviors. Medical issues can be difficult to completely rule out in somatic symptom disorders. Symptoms may be present in the context of a normal physical examination, laboratory, and/or imaging studies. It is also possible that there is an identifiable underlying medical diagnosis, but the patient's symptoms are out of proportion to what would be expected for that underlying diagnosis. Generally, by the time that a somatic symptom disorder arises for psychiatric consideration, a patient has had an extensive medical workup already. However, mental health professionals can get involved at any time during a medical evaluation for suspected somatic symptom disorders. Remember that physical symptoms themselves can be distressing, which can further amplify symptoms. Not having a medical answer for mystery symptoms also increases stress. So somatic symptom disorders are not simply all in a person's head. It's much more complex and requires a multidisciplinary approach to evaluation and management. Substances or medications that may also have physical manifestations must also be considered. Sometimes iatrogenic effects of medications can worsen symptoms, so a thorough review of medications and responses is helpful. Somatic symptoms can be seen in many other psychiatric disorders, such as fatigue and depression, sleep problems in almost everything, and recurrent headaches, stomach aches, and muscle tension in generalized anxiety disorder. Fear of a defect in a specific aspects of one appearance may be due to body dysmorphic disorder, which should also be excluded. Somatic symptom disorders are also highly comorbid with mood and anxiety disorders, as well as some personality disorders. This only increases the complexity of diagnosis and management of this set of disorders. With exclusion of other causes of symptoms that are medically unexplained or out of proportion to another underlying diagnosis, one of the somatic symptom disorders should be considered. From there, it's useful to consider whether or not there is evidence that symptoms are intentionally produced. In the vast majority of somatic symptom disorders, symptoms are not intentionally produced or feigned. Somatic symptom disorder is characterized by one or more symptoms that are distressing or disruptive to one's life. The symptoms can be vague, such as fatigue or malaise, or more specific, such as localized pain. The symptom can also present as exaggerated normal body sensations. The symptom is accompanied by thoughts, feelings, or behaviors that are related to the symptom that are excessive. Examples include persistent thoughts about the seriousness of the symptoms, disproportionately high anxiety about the symptoms or one's health, or excessive time and energy devoted to symptom or health-related concerns. And these symptoms and behaviors are persistent, lasting in general more than 6 months. Functional neurological disorder, formerly known as conversion disorder, is diagnosed when the distressing or disruptive symptom is neurological in nature. The system is not consistent with patterns that would be expected from a known neurological or neuroanatomical process. In illness anxiety disorder, formerly known as hypochondriasis, the predominant feature is not a symptom. The core feature of illness anxiety disorder is a persistent, usually greater than 6 months, fear of having a serious illness. Somatic symptoms, if they are present at all, are mild in severity. Distress in illness anxiety disorder does not come primarily from a symptom, it comes from fear of possibly having a serious illness. If a symptom is present, there may be excessive fear of its meaning or its cause. There is a high level of anxiety about health, and affected persons may engage in excessive health-related behaviors, such as quote-unquote doctor shopping, or conversely may be so worried about having an illness and receiving bad news that they may alternatively avoid seeking appropriate health care. In the previous disorders, the symptoms, if present, are not intentionally produced or feigned. There are rare times, however, when symptoms are intentionally produced. We currently recognize two main categories of motivations for these behaviors. The first is primary gain. Primary gain refers to being in a sick role or some other internal incentive, such as getting some comfort or other emotional needs met. Before dismissing an apparent attention-seeking behavior as such, it can be helpful to consider why someone might need to get their needs met in this way. The other is secondary gain. This refers to external incentives, such as getting disability, time off of work or school, avoiding legal consequences, financial gain, or some other external motivator. In factitious disorder, symptoms or illness is produced to assume a sick role or another primary internal incentive. The individual presents as ill or injured and may have engaged in self-injurious behaviors in order to induce illness or injury. There must be evidence of deceptive behavior which can be difficult to obtain in a clinical setting. If the affected individual feigns symptoms in themselves, this is diagnosed as factitious disorder. However, if an individual feigns symptoms in another, such as a child, this is diagnosed as factitious disorder by proxy. Factitious disorder by proxy was previously called Munchausen syndrome. Factitious disorder by proxy should raise concerns for abuse, as the victim is often a vulnerable person. Malingering is the feigning of symptoms for secondary gain. It is not technically a diagnosis because there's no psychological or psychiatric underpinning to it. As such, there is also no particular psychiatric treatment for malingering. Malingering can be and often is a maladaptive behavior motivated by avoiding work or legal prosecution, obtaining financial compensation, or manipulating other situations. But malingering can also be an adaptive behavior. People can pretend to be ill to get out of captivity or to get basic needs met. Getting a sense of the function of the behavior can help assess next steps in management. Now let's tuck the somatic symptoms disorders back into the bigger overall diagnostic framework. To summarize, somatic symptom disorders are characterized primarily by symptoms that are either unexplained or not fully explained by an underlying medical etiology. They are diagnoses of exclusion. Patients with somatic symptom disorder, functional neurological disorder, and illness anxiety disorder do not intentionally feign or produce symptoms. Somatic symptom disorder is characterized by one or more persistent, vague, or specific somatic symptoms and excessive behaviors regarding those symptoms. Functional neurological disorder is characterized by one or more neurological symptoms, not explained by a neurological process. Illness anxiety disorder is persistent fear of having a serious illness, and somatic symptoms, if present, are only mild in severity. In factitious disorder, symptoms are intentionally produced or feigned to assume a sick role or other primary gain. In factitious disorder by proxy, symptoms are intentionally feigned or produced in another. Often the other person is a vulnerable individual, and this is a form of abuse. Malingering is a term used to describe behaviors that produce symptoms for external gain, such as money, time off of work, food, or other reasons.